Welcome. We're so thrilled that you all have joined us today. I'm Sarah Zanton. I'm the Dean of the Johns Hopkins School of Nursing. And today we'll be looking at the nursing crisis or shortage or time or whatever you want to call it from all angles. And we'll have a really lively discussion. We're so lucky to be moderated by Joanne Kennan. She'll be introducing the panelists. And before we start, if people could introduce themselves in the chat, if you could put your name and where you're from and anything else you want to say about yourself. We'd love to learn more about you so we can make sure this is as relevant as possible. Take it away, Joanne.
Hi, everybody. I have a panel of, I guess there's 5 experts here in nursing and particularly in the workforce, the nursing workforce. I'm just going to introduce them very briefly, and their full bios you can find online. We've got Sheila Antrim, who's the COO and the Senior Vice President at University of California at San Francisco Health, where she tells us it is actually as nice as it looks on her background picture today. Gretchen Berlin, who's a senior partner at McKinsey, who's looked a lot at the nursing workforce issues, which is what we're going to be discussing today. Bianca Frogner, right? This is the director of the University of Washington Center for Health Workforce Studies. Robin Geiger, who is the senior vice president and the clinician advocacy at Ingenovis, which I think I'm pronouncing right. You can correct me if I'm not. And that's one of the major staffing agencies. And Matt McHugh is the director of the Center for Health Outcomes and Policy Research at Penn, School of Nursing at Penn. I've asked everybody to just sort of be ready for a quick lightning round question to get everybody in the conversation quickly, and then we'll unpack it. Do we actually have, when we talk about a nursing shortage, do we actually have a shortage, as in not enough bodies? Do we have an allocation problem? And allocation is not exactly the right word, but is it really more of an issue of, do we have the right people doing the right jobs in the right place at the right time? So allocation is sort of a shorthand for that. Or is it a satisfaction issue? Are there people who really want to be nurses but hate what they're doing right now? Or can't, is that why they're leaving? Because it's not that they don't like nursing, but they don't like what their experience of being a nurse is at this particular time and place. The nursing, the shortfalls and the work shortage crisis predated the pandemic. The pandemic only made it worse. The demographics are challenging in the coming years. So I'm going to sort of call on you in the order that you're on my screen, and get your just really quick response to that question. Let's start with you, Sheila.
Spoken from a critical care nurse, I think it's all 3, and we can come back around to it, but I think it's everything that you mentioned, and for good reason.
Robin.
I agree. I think there's contributing factors from all 3 of those elements, and they can be varied depending on the situation and the area of workforce or demand.
Matt.
Agree with Sheila.
We do not have a supply shortage. We have a shortage of care at the bedside. That is a function of at least 2 of those items you identified. Fixing all 3 or improving them wouldn't hurt, though.
So we have enough bodies, but we don't have them taking care of patients where they're needed most.
Well, producing more bodies will not solve the problems that we have.
Right. And Bianca.
So I'm going to be in the camp of all 3, but I'll certainly put an emphasis that it's on the allocation issue, kind of probably being a fundamental problem that needs to be addressed and solved, is that we need to get the right people in the right place doing the right thing.
And Gretchen.
I will second Bianca on allocation, and I would say not just allocation of nurses, but of the full care team, to make sure that nurses can focus on things they're uniquely qualified and want to do.
Because having covered Congress as a journalist and covered policy in Washington, when people hear workforce, they think bodies. They think purely and simply, we do not have enough bodies. And if you had asked me a year ago, I would have said there are not enough bodies. So I think this is a really not just an interesting conversation we're about to have, but an important conversation as you go back to your worlds to explain. I don't just mean bodies. In some fields like nursing homes, it is bodies, but it's not just bodies. All right, let's just sort of talk about that. Gretchen, you've looked at the numbers a lot. I mean, other groups have, but McKinsey has looked at the numbers a lot. And when you've looked at the shortfalls, both in terms of who's already quit, that a lot of younger nurses have quit, which isn't just care today, but the leaders of tomorrow. And then there are more who are thinking about quitting or saying they want to quit. What is sort of where are the 5 alarm fires there as opposed to the 2, 3, and 4 alarm fires?
Yeah, but just to paint the kind of macro picture, we have been looking at those who want to quit now since the sort of, I don't know, second inning of the pandemic, call it. It wasn't right at the beginning. And I think we're one of the first people to speak on, at the time, 20% saying they wanted to quit. It went up to 30 and it's persisted at 30. Also, I saw some comments in the chat that folks have joined from around the world. We've looked at that across countries, and the US is not alone, which maybe we can come back to, because I think often people say, well, why don't we just bring in folks from other countries? And that's not a real option. But to your question specifically about where is it most acute, what we've seen is, that 30% intent to leave becomes 40 in the inpatient setting and becomes as high as 50 when you get to sort of the med surge floors. So back to the, allocation versus bodies versus, dissatisfaction, it probably actually looks different by care setting, but the worst that we see is in the acute med surge.
Sheila, you're in a healthcare system in a tertiary center, an academic medical center, a center that had its share of pandemic cases. How did you struggle with getting enough nurses in the right jobs in your institution, which includes both inpatient and community services?
Yeah, I think that's right. I think that where we struggle today is in 3 major areas: in critical care, the operating rooms, and then believe it or not, in some degree, ambulatory care, where although a lot of people are switching over from ambulatory, from inpatient to outpatient. So oncology, for instance, is another area we struggle with. And I think however, we have a large degree of people coming into the system. So of the 60 or 70 slots that we have for new grads, we have over 1,000 applicants. So it isn't, that didn't become the problem. The problem is, I think for us, how do people move through a system, and how do we actually take away some of the redundant work that needs to happen, so that people know, okay, this is where I'm going to land up, here's what I'm going to do relevant to the next 5 years. So I do think that career projection is something we have to do immediately, because I think that current state and new nurses want to know, how long do I have to be on a unit? How long can I be? How long does it take me to get to this projection? And how do we actually incorporate that into their jobs and make a structure that's there? I echo also what someone said around the care teams. We no longer can just say it's just nursing. There's pharmacists, respiratory therapists, other people who we need to start to consider how they play a role in both the bedside, ambulatory, ORs, and make sure that there's enough of them to also be able to form a team and be able to take it from there. So I think those were the most important things.
Robin, I think people outside of nursing, people didn't know what a nurse staffing agency was, or what a temp nurse was, until the pandemic. It entered the consciousness of the general public. I mean, you certainly were able to surge. If the pandemic moved around, we'd have a bad month in Missouri, and then it would hit New York again, and then Seattle, and I mean, you got people where they were needed, and yet there are also, it's a controversial field, as you well know. That the temporary nurses from the agencies make more money than the home-based nurses, that there's some cultural clashes. Maybe that's too strong a word, but you're in a place and you know how a place functions, and then somebody else comes in and there's sort of some, I'm not a nurse, so I've never experienced this, but things I've heard about and read about. I mean, where do you see the role of agencies like yours ongoing as we get into a world that's not pre-pandemic normal, but whatever our next normal or semi-normal or fake normal is going to look like.
Sure. Yeah, I'll try to answer all of it in between. You gave me a lot there. But certainly, staffing agencies, companies, they've been around way before the pandemic. There's always a need, and we're proud and excited that we can support and fill that need. What I'm seeing is there's more of a shift to collaborative care models that include staffing workforce solutions companies like ours. And we're proud to have those conversations and be a part of that solution, because the ultimate goal is safe patient care, right? And safety for clinicians. So if there is an area where staffing support is needed, instead of allowing the clinician to suffer at the point of care or the patient to suffer at the point of care, that's where we would come in. And in Genovis, of course, we definitely have our number of different companies that support different kinds of solutions, including, strike and cardio and ambulatory and allied. And there's always, there's been a need and there's a continued need. But what we see mostly is that the need for the clinicians have shifted. So we created an ACT program or something. It's called the ACT program. It's fostered around advocacy, career, and tools to support the clinicians at the bedside to enable them to coexist and blend well in those assignments. So we want to make sure that they're happy and that they're resilient, and they're having the same struggles that bedside nurses are having, permanent bedside nurses are having. But what we're finding is that they're happier, and the agencies that we serve also feel that there is still that continued need. They love the fact that we're providing that additional support. So I think there's a couple things there. There may be some misunderstanding on what workforce solution companies actually can do for health systems and how they support, and not that, that there's a competition there, including with salary or pay. So you're paying someone more because they're out of their element, they're traveling, they don't have the same benefits that a permanent staffing or a permanent solution nurse would have. And then if you think about it, the actual health systems, they are actually paying a little bit more than what they're thinking. If you allocate the funds that they're providing per nurse in that health system, it's not just salary, it's actually a whole package. So when you're considering that, it's actually a really smart decision. And what makes sense is to plan ahead or have a collaborative model that works instead of being reactive, maybe proactive to plan those percentage of whatever staffing workforce solution makes sense in your planning, because it will always be nurses that will decide to go somewhere else or change careers or change paths, and there'll always be that shift.
As you're talking, that we've got people in the chat who are nurses talking about, they were working in as a staff nurse, and a travel nurse was making 4 times what they were making doing the same job. So there is a tension or
Oh, absolutely. Right. But still there, again, hopefully they'll understand and be able to see the added stress with traveling across the country and staffing somewhere that you don't know anyone, you're not being well received. You still have to assimilate to a new environment. Some of those funds still have to go toward however many residences you're keeping, whether it's 1 or 2. So I think that there is some heightened expectations when you're a travel nurse, but you may see that you have that ability, yes, to be in a new area and a new environment, and we love to give that to our nurses, but they also still have some struggles that other people they're not accounting for those struggles.
So Matt, coming into the, you came in really strong saying it's not bodies, it's it's where we put in the bodies. Bodies is not a great.
It's not bodies yet.
Okay.
It will be.
What do you see are sort of some of the promising solutions, and do you see them bubbling up sort of in the academic world that should be tried, or do you see people and health systems coming up with ways of addressing who should be working where, who is doing things that it's not exactly at the top of their license phrase, but like really nursing as opposed to things that people with less training can do, and can you redefine the job so they're doing more of what they were really trained to do? Are you seeing, are you seeing things that work?
So I'm seeing things. I think the jury is out on things, whether they work or not. I think that there's a lot of, I mean, just seeing innovation and team, those things seem to be kind of universally accepted as positive things without necessarily empirical basis. I think, Sheila, you had talked about some ideas that I really support around, building a career and making a pathway so that people can maximize what it means to be a registered nurse for their lifetime. And that, I mean, nursing as a profession is kind of the classic wage compressed employment situation. And so some of those things I think are really important. I think the degree, well, we know to the degree, we've studied nurses since 1999, every 5 to 10 years. And we know that the busy work, bureaucracy, red tape, unnecessary policies, unnecessary documentation that actually makes nurses work more difficult has increased exponentially. And those are things that I don't think investing in more people is the solution to. Fixing those things is part of it. And then looking at, I mean, nurses are definitely doing things that is not the best use of money for the nurse as the professional to do it. And so I think there's a role for all of those. I don't think that there's going to be any one. My fear is that, we're looking for a silver bullet for the AI or the virtual nurse or the agencies alone, which, by the way, I think agency nurses got villainized in a way that was totally unacceptable and that the evidence does not support. Evidence is very clear, actually, once you account for the lousy circumstances that often necessitate bringing in more nurses because the other permanent nurses have left. Often, thank God for the travel nurses because things would be much worse without them. And in many ways, they saved the failures of our healthcare system, which would have shut the lights off and shut the doors of many hospitals if they weren't available. And, frankly, there are few opportunities to increase your wage as a nurse. And I don't blame nurses for, taking, everyone else is capitalizing on capitalism. And, instead of saying the travel agencies are charging too much, again, I mean, there are cases of collusion. Hospital associations have called for the FTC to investigate and for Congress to leverage its power focused on the travel nurses. That's an inversion of the problem. So that's not me pointing to any solutions, except to say that we shouldn't be distracted by things that aren't the problem. And so we can take them kind of one by one and apply an empirical lens to them. Test, and what works, then we apply. Test and apply. We got to move into a rapid cycle of trying things, but not just believe that because we think it's new and shiny, it's going to fix things.
Just like if hospitals are willing, I mean, this is something that's come up in the chat too. If hospitals are willing to pay travel nurses more, why aren't they willing to pay staff nurses more? Bianca, do you want to? I mean, is it just because it's temporary and they're going to pay these nurses? But you could also have temporary. I mean, there are ways of having different kind of workforces. What's going on? Is it just
apparently the money was there.
Well, that's a great point. And I think, travel nurses are really a symptom of a larger problem. Certainly a problem that existed before the pandemic, which is that we're not doing enough to maybe care for our nurses and listening to them and hearing what their needs are and addressing them. I think that staff nursing issues that have come up is also a symptom of just the kind of poor pandemic kind of planning we have in this country. We don't have a mechanism really to surge our workforce broadly during widespread pandemics like this. I mean, it's a rare situation. We can usually find ourselves surging in the use of staff nurses when there's local emergencies, right? And then we can kind of move people from places where there's more slack to a place that there's more need. And in this situation, the whole country was kind of in need at the same time, and we're all pulling from the same pool of people. And when you also have the whole entire world kind of struggling with this too, are other avenues to pull people, which is through international migration. that was also a limited pool. And not only that, this wasn't just affecting nurses. I think that Gretchen, I think, mentioned it before, and I think Sheila, you also addressed it too, is that when we talk about what's happening to nurses, it's really about what's happening to the health workforce more broadly, because nurses are being affected by what is happening to staffing in other parts of a hospital or other settings. So for example, nursing assistants, there's such high turnover among nursing assistants, and especially in hospitals, in long-term care settings. And when we see a short supply of nursing assistants, well, somebody still has to do the jobs of the nursing assistants. And so this kind of gets to the allocation problem, is that registered nurses start doing tasks that just aren't really appropriate for their level of skill and training. And similarly, when long-term care, especially skilled nursing facilities, struggle with recruiting staff, well, it creates a backlog back to the hospitals. And again, it creates more burden of work for hospital nurses. So again, I think going back to the travel nursing part, it's a bit of a symptom where we don't have a system of care to really move people around properly, and we didn't have mechanisms to surge people. But in addition to that, it certainly raises questions as to, well, how do these hospitals manage to pay for these travel nurses? Could we have done more to invest more in retaining the nurses that we currently have? Which is, I think, what probably Matt is probably had alluded to at the very beginning of this conversation, which is, we can't train enough people to get ourselves out of the issue of finding enough people. We have to also figure out how to keep the people that we have and make them happy.
Sheila, what do you hear at your system at UCSF? What do nurses tell you they want? Part of it is making them want to stay. Part of it is money. You're in California. There's the nursing ratios in California. The mandates are there that are not in the rest of the country. It looks like CMS is going to come out with something about nursing home ratios. I don't know exactly what they look like or how long it'll take to be phased in. And I don't believe that it's sector wide. I think it's nursing homes, not all nurses. But what are you hearing from, if you're losing nurses? Do any of them come back? There's ongoing issues with the healthcare system and what the nurse's job is versus what a nurse wants her or his job to be. There's the pandemic burnout, which, whatever your profession is, journalists burnt out in different ways. What are they telling you that you can do, and what are they telling you that you're still can you say, I can fix that? And where do you need other players in the healthcare system to help you? Where do you need the government to help you? Where do you need California, you're very unionized. And just gives an example of sort of like, the sort of typical exit interview, or the typical, I'm threatening to go, I'm thinking about leaving pre-exit interview. How do you stop it from becoming an exit interview?
Yeah.
That was a long question and I didn't word it greatly, but you know what I mean.
Yeah, no, I do, Joanne.
Make them happy.
I'm going to go back to Bianca's point in that prior to the pandemic, the system was sort of broken at that time. And so we've had a lot of folks who come in contract labor, and they've been converted into permanent employees. I think the issue, as germane as it may sound or trite, is culture. If you have a culture within your institutions that brings people and kind of moves them to a process of understanding how things work, you've got to have a little bit of that, number one. Number two, nursing has become very transactional. And so I think that it's always a thing or a point versus a plan. And so for us, when I sit and actually have interviews, what I always feel is that it's better for a nurse to move within the system or move within the hospital, move around, than it is to actually move out altogether. California, yes, we have ratios, but it is very expensive, and people's husbands and partners have lost jobs. And as they become the sole breadwinners, they need to go where the housing is not so expensive. And so there's more than just, I don't like my job. It is a movement of everyone to get to a place where they can actually have a better life outside of the hospitals and outside of the organization. So I think that for us, things that people talk about, parking. So they don't want to pay for parking. They want to have, it's things that are more infrastructure related that we are actually now trying to figure out how to solve, because you know, the campus needs revenue, and we don't have the revenue streams at this point in time to do that. The other piece of this is patients themselves. And so I do worry that over the last 3 years, in the upcoming 3 years, people were not trained in nursing as the old guard. And so you run the risk of people being burnt out, of preceptors who need to precept these people that are burnt out. And so you have more mistakes and you have to have more oversight. And so I think that regardless of where we go, we have to plan for the fact that we need longer times in orientation. We need longer times during this process to make sure that the harm and health of patients is not at risk. So I think those are the things that are most important, and those mean maybe more surrounding of people. Sorry, Matt, but we have to put more people around the people in order to make sure for a while that those harms don't come. I definitely know for a fact that people were not, and we just didn't have schools that would allow practicum to actually happen for people to come in and do those during the time of the pandemic. So people lost out on time and training that we need to make up for over the next 3 to 4 years.
Richard, are there,
Can I just follow up on that?
Yep,
No, and Sheila, I absolutely agree, and I think, you know, a kind of blind push for more people is actually starting to kind of point towards some a complementary issue. And, you know, we saw in Florida the fake degrees. We're seeing nursing schools, fly-by-night things just pop up, for-profit things. We know that pass rates on NCLEX are on the decline for the first time in as long as I could ever remember. And so, you know, it's not just the quantity, the quality, and making sure that even the best quality new nurse can be successful. And that requires more than just having other people around. But yeah, we need to onboard them. We need to invest. I mean, when I came out, you know, it was unheard of to put a brand new nurse in a children's hospital, peds ICU, where, you know, you have the most critically ill of critically ill. But I mean, that is happening now. We're putting nurses after days of orientation into positions that no one would seem is reasonable, but filling them and not having a real plan around how to help them be successful. And I think in many ways that's, you know, I think that nurses often feel kind of gaslit around, you know, they're working as hard as they can in a system that is inherently undermining their ability to do what they have been trained to do. And that would be frustrating.
Right.
Um,
I'm sorry, Joanne, if I could add to
Sure.
that. To what Matthew and Sheila spoke on this as well, on like parking benefits and just making sure that nurses feel supported is huge as well. And what I'm seeing is that like we did an internal survey, quite a few nurses within our company of brands, and 55% of the nurses were really more focused on the benefits, career support, having that mentorship on career ladder. I mean, what's in it for me? What support do I have? And I think I know that we're talking about, you know, recruiting more nurses into the profession as well. But what are we doing for the nurses that we already have to retain them and make sure that they feel needed and that they feel valued for what they're bringing, regardless of which position they're in, whether they're a staffing nurse or a permanent solution nurse? It's important that we provide those solutions. And, you know, I think a lot of times I'm seeing health systems that they're saying the right things, but they haven't yet skipped to providing those additional benefits and solutions that would keep them, that they would want to stay. So that's something that's really important that we need to, and it's more of a interdisciplinary approach, like Matthew's voice, everyone, we're all different here. I think having that varied voice, that different group at the table is important, not just nurses. We want to know what everyone thinks. So this is a good way to do that.
Richard, you had some points you wanted to make. I mean, it's the economic stresses post-pandemic are system-wide in many hospitals. Looking at just like paying nurses more is not as, or, Sheila said, that, they wanted free parking. I mean, that's not what would have, if you would ask me what nurses want, it wouldn't have occurred to me. But, and I guess with all your nurses, it adds up to be a fair amount of money in San Francisco. What are some of the larger sort of macro issues in the healthcare sector that this nursing shortage or nursing crisis is playing out against?
Yeah, thanks for the question. I would just say that everything that my co-panelists have articulated in terms of what nurses want, we've seen in our surveys. The one part that I would add is the flexibility component as well, which I think is also a broader societal shift that is happening across industries, and nursing, but broader patient care can't be left as one of the only careers standing where you have to be, in person all the time. So that's just one thing I would add to that. But to your point on the broader economic piece, I think it underscores the need to look at a lot of these challenges through the full systems lens. So to the example of if there are staffing ratios coming for nursing homes, that obviously may be very helpful for nursing quality, but will likely have knock-on impacts for the ability to discharge from the inpatient setting. So like we end up in this game of whack-a-mole. And I think a lot of the considerations, I don't mean to speak for the health systems on the panel, but about just raising wages as a solution, labor costs are, 50% of health system expenses. And since COVID, we see sort of 25% annual increases on the input costs into healthcare that haven't fully flown through into premiums, whether that's on the exchange, in commercial coverage, or to government. And so it just underscores, frankly, we're here talking about the nursing part in particular, but it is also a symptom of a much broader, frankly, broken healthcare ecosystem we're a part of. One of the questions in the chat was, what kind of data do we operate on in a country, and how do we plan our workforce? Like the short, somewhat flip answer to your question is we don't. We have national data, it's extremely delayed, but we don't really have any of the central planning that the NHS has in the UK. And we're all trying to work together, but it really is a broader systems challenge.
And if I could add to that, just in terms of data piece, a lot going back to the idea of bodies, right? For the most part, the only kind of data we really have is count of people. We have no real idea what people do, at least not at a national level. And on top of that, we don't do national health workforce planning in this country for any profession.
Right.
And that was very clear.
There's a question from England with a lot of questions about our data and planning, and I think all the Americans here are saying, wrong country. Right?
Yeah, and it's true. I see the person, at least someone from the UK, maybe they don't necessarily do central planning either very well, but in a lot of ways, workforce controls happen at a state level. That's where licensure tends to happen. So that does tend to be where a lot of legislative action tends to happen, is at the state level. And that can be, I think became problematic during the pandemic, because we were all looking around at each other like, well, what are you all doing over there? And we didn't even have a central way to communicate with each other about solutions. I think health systems also don't really have a clear way to share with each other solutions, and nor do I necessarily think that they want to, because there's certainly a competitive advantage to doing something right at their institution that then attracts nurses or other kinds of staff. But I certainly think we need better ways to share information about what's working, what's not. And as Matt kind of pointed out, we don't really have a lot of great data even on what is working. We just know things are happening, and even just starting with just cataloging what those things are is certainly a place to start.
This is a really good question, because we're all aware, we're talking about burnout, but part of burnout is part of the larger mental health crisis in this country that is, everywhere, right? We all know it. So how much, we use the word burnout somewhat loosely, and for some people, this burnout really is a mental health issue. Post, what the critical care nurses went through is something that I can't even fathom. How much attention is being paid to those needs? Anyone who wants to answer, and is it a fairly big part of the current solution of people wanting to leave it's not just that their feet hurt or that they're don't like their parking, that there's this larger sort of existential suffering. Given what nurses have experienced and been asked to do since 2020. Matt, did you signal you wanted to answer?
I think Sheila has her hands up first, but I'm happy to follow.
You know, I think that part of it is the exit of nurses who were my friends that I depended on and that are no longer working with me side by side. That then becomes an issue of who do I actually trust in taking care of patients on a unit or in a department. And so I do think that, Joanne, that's part of the burnout, number one. Number two, everybody has families and everybody had a personal life of which some of this has nothing to do with the actual job itself. When here at UCSF, one of the amazing things we did was to put into place a app from a program called Code. And from an app, you could actually get to a mental health provider to be able to have a conversation and be able to schedule time to go through and talk about things that were happening in a very private way. And we found that there were so many people that took advantage of that we are still keeping it going today. So I think that there's the job itself, and then there's the actual environment. And I think that the other part of it, we would be remiss to say, is just the racial tensions in this country. Everything now is just a problem. And so all of that you have to put into the perspective in that it may have nothing to do with my job. When I walk out of my job and go home in my neighborhood it all comes back in a flash. And so I think that those are the things that we control as a health system. And then I think there's things that we support, knowing that the environment and what people are going through. And so I think that is, to me, part of that big word burnout and trying to resolve it. I think that the word resilience becomes a factor. And so we have many places now where people can go and just take a breath and just be for a while. That's not the solution, but it is a moment of which then I can just take a breather and just do that. So not exactly solving anything, but I think it's acknowledging the issues and trying to at least get people to talk through them to get to the other side.
Matt, did you want to comment on this?
Well, now I think I'll follow up on the things that Sheila said, which got me thinking about lots of other things, which is good. I mean, I totally agree on the idea of resilience gets, it's a negative rap, and it's probably a neutral thing in and of itself. In the abstract, a great thing. Building resilience, increasing opportunities for meditation and stepping away and all of those things. What we hear from nurses in the surveys that we do is that it's when those are the only things, it's very hard to step away from the floor and relax when you know that you're going to go back to a absolute disaster, or you're going to end up having to stay longer because of the time that you missed when you really just wanted to get your documentation done. And so in isolation, I actually think, and I had this discussion with, a very large hospital system, all of their wellness officers, and they knew this. They know that it's bigger than what they can solve. It doesn't mean that what they're doing is not useful, but I think that nurses will often resent when that's pitched as the solution, because that's pointing at the individual. The problem is not around the individual. Every individual would benefit from support, from doing hard, emotional, interprofessional knowledge work that is high stress and uncertain. And I think that, providing the resources that they need in order to do that hard work, that's the core. Nurses get burned out because they have to fix system problems, not because they have to take care of complex patients. That's what they went into the profession for. They want to take care of people. They don't want to take care of the EHR system, or the fact that the medication never gets there, or the fact that they have to find someone to cover their shift, or they're being mandated for overtime because the manager didn't have things on point.
If I could, I'm sorry.
Go ahead, Sheila. Go ahead, Robin.
Yeah, okay. Yeah, if I could just respond a little bit to what Matthew and Sheila was saying. So Matthew, I agree, one Band-Aid, it doesn't fix everything, especially one fix doesn't work for everyone. So providing those apps or resilience or whatever, some people find them amazingly helpful. Some people don't have time for them, but not providing them is not the solution. They need to have those resources and tools because it does strengthen and resilient some. And then the other thing is what I'm seeing is just even companies having advocacy, someone to have that extended voice to recognize the ability, the need to acknowledge the nurse, to find them valid. I know VA has a chief well-being officer, Mayo has a chief caregiving officer, and then my company, of course, an SVP clinician advocacy, where we're really dedicated to making sure clinicians are okay. We have clinician engagement partners who can talk to them, point them in the right direction, whatever they need. So it's not just giving them resources and tools, but those are definitely a help. What's important is making sure that they have someone to have the conversation with, and that they also feel and know that they're being valued, that there's someone out there that's working specifically for them. That's also really important.
I have a question for you that I'm going to come back to in a second, Robin, but I wanted to ask Bianca, or maybe somebody else wanted to weigh in this too. I've talked to some hospital executives recently, and then it's also come up in this conversation, like, okay, we're going to have the nurse really focus on the patient. The nurse is going to focus on the bedside. The nurse is going to do what the nurse is trained to do and wants to do, and she'll be happier. I'm saying she, but well, I'm going to move on. The nurse is going to feel like the nurse is really fulfilling her mission and what she wants to do. And then when I'm hearing, there's all these comments in the very active chat, and then in the formal questions, what allied professionals are going to back me up? We don't have enough of those either. You want me to free me up from documentation? You want me to free me up from this bureaucracy? You're feeling, who's going to do it? That those shortages, the what should be the backup aren't there, and therefore, you're not relieving me. I mean, how common is that?
Well, I think what goes through my mind is that, I think when we talk about documentation, the challenges around that, I'm not saying that that's not a problem, but I think when we focus on the person and what their particular challenge is, like, that's not enough to just solve a particular person's problem. We have to go back and say, what are the systems that are broken that we have to fix? So EHRs generally are complex beings that we have to think about administratively, how to kind of reduce that burden there. But I would say there's also some points that Sheila made earlier about, I think the fact that nurses are people. They had a life. They have a whole life outside of the work environment that was really upended during the pandemic, and I think continues to be a struggle even now. So, for example, childcare. Many, as you pointed out, Joanne, many people who are nurses are also women who also may have children. But even men who are nurses, they may also have families at home. And some of
their caregivers for the elderly,
or caregivers, exactly.
Forget about them all the time. Yeah,
exactly. And so, where are the supports there to help either get affordable childcare, affordable senior care? Where can they kind of get that? Where can they get it at the hours that they need it? And in addition to that, I think we have a general problem around kind of availability of mental health providers. I think that was a comment that was made somewhere in here. So even if we wanted to encourage people to go get the mental health care that they need to address burnout that they might be feeling, well, we don't really have sufficient numbers of behavioral health workers to take on that increased demand, unfortunately. And so what are our solutions to that? But then in addition to that, there's a lot of stigma around admitting that you might need that additional help. So where is our protections in place that allow nurses to feel safe to say, hey, I really do need help here? And I think we have to really step back and say, what are the system level problems here that really need to be addressed? And some of them are really outside the borders of healthcare. That many of these solutions are within kind of more social services sectors that we need to think about. How can we use the voices of nurses to help push those conversations forward? And I certainly have heard a number of nurses entering Masters in Public Health programs. I saw someone ask, how do you get involved in health policy? Well, there are nurses who are joining MPH programs so that they can get some health policy training so that they can be on the front line of creating the solutions themselves.
The question I have for Robin, and I want to follow up on what Bianca just said too. We hear these stories about X percentage of nurses, or hundreds of thousands of nurses, or 1 in 4 nurses, whatever, is leaving or talking about leaving or thinking about leaving. What are you seeing in the travel contract sector? Are you also having that kind of, I want to leave and therefore I'm going to go make money for a year so I can leave? Or is it, I thought contract life would be better, but I'm just as burnt out as as I was before, and I still want to leave? I mean, do
That's
you
a
have
good
data?
question. Well, actually doing a survey for your question, no, but seeing the impact, yes. So the nurse burnout it's universal. I mean, we're having that within staffing and workforce solution companies as well, which is why we created an ACT program to support nurses, to help them and provide support, because it's everywhere. I don't think that there's anything that's different. I mean, everyone has a work-life balance issue, or many people have sick family members, many people are sick themselves. I don't think life is different outside of work. And so I echo what Bianca was saying. Some of this is definitely outside of work, but it becomes a health system issue when they come to work and there's maybe patient safety concerns, or there's clinician safety concerns, or they don't feel protected, or they don't have psychological safety to speak up and say, hey, I just don't feel okay. So I think that that does become our problem. And that's why these panel discussions, keeping the conversation going is just really ultra important.
The very quick question from the nurse in England who wanted to know, who we all, said, no, we don't have great national data. She's now asking about states. Is the best place for her to look each state has a state nursing board? Or would that be the place for someone interested in planning? They don't do a great job in planning either. Is there a single point? Is anyone looking at the states? We're just as bad at the state level, worse, as bad or worse at the state level, right? Data is not our, we have a lot of data, but not the data we need. And the other thing is, I want to give you all a chance. We've talked about a lot of things and we don't have much time. I'm going to sort of go, I'm going to sort of something that you need from outside your system, a solution, whether it's, and we also didn't really talk about, maybe somebody will bring it up. We didn't talk about the pipeline because we also don't have some of this solution is 20 years, starting now for the next 20 years. But the question I was going to ask is, we see these forecasts, 800,000 nurses want to quit, et cetera. And we've been seeing them for years. Are they accurate? Do people who want to quit actually quit? Matt, you're nodding.
Well, just in terms of accuracy, we just took a look at, for the past 20 years, HRSA and a number of independent investigators have done projections, and, they get better as you get closer, but we benchmarked relative to what, going back to the year 2000, what they said, we would need in 2020, and they were all wrong by significant orders of magnitude. And at some point, even when they said that there would be an excess of nurses, we actually are above what was stated as an excess. And so I don't think that, and again, part of it is a function of, labor market models are inherently to help inform employers. They're not to do healthcare workforce planning in a way that helps us understand, do we need to expand nursing schools or not? In many instances, if you are not working, you do not exist in the data. And so I think that there's a place for multiple sources of information to help triangulate and come to a better understanding. I mean, there was a workforce center as part of the Affordable Care Act that I think ostensibly exists, but is totally
I don't think it ever got
defunded.
funded.
Yeah. So
Anders.
it's possible. I do just want to follow up. I think it's a really key point that Bianca and Robin were making, and I'll just point an anecdote that in work that we did in Europe, we asked nurses and physicians about what in the literature are a number of interventions that have been focused on improving well-being and quality of life. And a lot of the things came from US literature and included things like childcare and support for access to different services. And they didn't know how to answer those questions because they have a social and public policy structure that makes those questions irrelevant for them. They just don't make sense. They don't pay for parking. They go to work, they have parking, and they're not shelling out $20 a day from, their employer just to give back to the employer to pay a parking company. And, in one way, it's also important to recognize that many countries did not respond the same way. If you look at the spikes of layoffs and quote discharges or firings, net of retirements and quits, the US stands alone in when the elective surgeries got canceled, nurses were sent home. And, they didn't know when or where they would be coming back, and many of them didn't return. And I don't often blame them because they had to figure out how to do it too. And all of the things around childcare and things when the schools closed, we had no safety net for any of those things. And so, at multiple levels, not just the healthcare level, we failed nurses.
So let's just, we just have a couple of minutes, and let's just sort of close with some, as we think about solutions, let's try to merge what we didn't talk about, which is a little bit, we don't have too much time, so just a really quick thought from each of you. There's some long-term structural issues here. There's pay and morale and things now, but the pipeline is also essential. So what do you want to see in the pipeline? And pipeline also has to be making a more diverse nursing workforce, because that's throughout all of healthcare. It's not just nursing. So who wants to take, Bianca, what do you see? What do you need to see? Looking at what do we need to do now so that we don't have this conversation in 20 years?
Better planning, better communication at the national level. I would love to just see kind of more coordination there, and going to that kind of comment that there was like a planning or an advisory committee that was supposed to have been created under ACA and didn't happen. I'd love to see that happen. But I think there's a lot of creative things that could be done to think about the longer term trajectory that even gets someone to the RN position. Like, what can we do to support our nursing assistants? And here in Washington State, we have some interesting initiative to do an apprenticeship program, which I think we could certainly do more of, which is allowing NAs to become LPNs, and that allows them to stay on the job, get paid, and get credit for it.
Okay, Sheila, are you doing anything in San Francisco to 20 years that'll bear fruit in 20 years?
I think that it's definitely, we have to set three to five priorities and be very explicit and intentional about them. So I'll use one in documentation. Documentation is one that we hear across, everybody has issues with documentation, but it is not going to go away, but it doesn't mean point and click everything we do it because of quality. We do it because of Joint Commission. We do it because of but what is a standard of documentation, nursing documentation across the country? Because the bottom line is, in this country, we are litigious. And so you have to do documentation, but you don't have to do it so much that it's just so ridiculous. So I think that really thinking through the day in the life of a nurse, thinking through what are the pain points, and coming up with 3 to 5 intentional things that we can do as a country. And I use documentation as the example, is something where at least it gets people at the bedside, people that are in IT, people who have the means to be able to figure it out, to be able to come together. So it has to be more than just what we've done today in data. It has, to me, there are things that we have to do that we could do to bring down some of the temperature and some of the issues of today.
Okay, I think we've actually time to turn it back to Sarah. It's really been an interesting conversation. I personally could have gone on longer, but I'm not allowed. So Sarah, thank you all for participating. It was a really good talk.
Yes, thank you so much. Thanks also for the questions in the chat. We will certainly scrape them. And I'm just so thankful that everyone was willing and able to come. I do want to say that here at Johns Hopkins, we are starting a Health Policy Institute in DC, and we have joint DNP, MPH, and all kinds of ways of getting an MPH with a nursing degree. So there's this problem is not going to be solved overnight. So come get your education well and figure it out for us. And thanks so much to all the panelists and to Joanne, and see you again soon.